Let's get started. Today's talk is on, as we said, where is Waldo and where is his ship? This is a great acronym, and this is something that I really think is so essential. We have seen 12-lead interpretation just expand over the last 20 to 22 years since really the STEMI guidelines started being developed and pushed into pre-hospital EMS. And we know that the standard criteria is great, but are we able to pick up on all these outside atypical 12 leads that have been identified over the years? Got to give all the credit to this acronym to Jared Patterson. He's a FOAMfrat educator. Wrote a blog back in 2019. It was republished in 2021 when the FOAMfrat website was revamped. And I have to say, this acronym is brilliant. This is an acronym I think is something that can save a lot of lives. We really need to spread the word. We need to teach this in everything we do 12 lead wise, because it really focuses on those tough 12 leads that if we're not able to identify, we may miss an opportunity to get this patient to a PCI center. And so Waldo's SHIP stands for W, WELLEN'S syndrome. A is AVR, left bundle branch block. D, Winner's T-wave. Then we're going to look at out-of-hospital ROSC, subtle inferior lateral MIs, hyperacute T-waves, and then lastly, we're going to look at isolated posterior walls. Objectives, we're going to discuss the acronym WALDO and SHIP. We're going to look then at 12-lead presentations that don't really fit the normal diagnostic criteria. We're going to examine why that is, look at any evidence related to those specific 12 leads, and apply these to the new acronym of OMI, or occlusion myocardial infarction. Let's first jump into WELLEN'S syndrome. WELLEN'S syndrome is that classic atypical presentation. This is not something that is super common, and so that's where we get into, are we able to identify it? We have to be able to study these. We have to be able to continuously refresh our minds, because the incidence of WELLEN'S syndrome is not high. These patients are going to be pain-free most often. They do get into a center, an ER, where they do diagnostic labs. You might see a slight elevation in cardiac markers. There's two types of WELLEN'S syndrome presentations, but really, and we're going to dive into those, the classic presentations, or those biphasic T waves in those precordial leads, V2 and 3 specifically. You're going to see symmetric inverted T waves, and that could be in any of those precordial leads. And so what does it mean? Well, as I said, pain-free, atypical presentation, but this is an indication of a severe proximal LAD occlusion. And so that left anterior descending artery is going to be stenotic, insufficient flow. And really, when we think about this from the big context, everything needs to be backed up by research. And there's research that shows that 75% of these patients will proceed to an anterior wall MI. It could be days, it could be weeks. And so it goes back to, again, what is our standard presentation? What do we look for? We look for, two contiguous leads. We look for 1 to 2 millimeters of ST elevation. And the tip here is you're not going to see significant ST elevation, if any at all. So let's dive into type 1 and type 2. So if we compare this to type 2, notice that the T wave is negatively deflected. The ST segment follows the isoelectric line. We have a symmetric T wave that is negatively deflected. And if we go back to just standard 12-lead interpretation, we know that your T waves should be physiologic in presentation, meaning that they should be asymmetrical. T waves should be asymmetrical in a physiologic presentation. When you start looking at T waves from a pathologic standpoint, that's where we get T waves that are symmetrical, whether they're negatively deflected or they're positively deflected above the isoelectric line. A symmetric T wave should always give you pause. So to compare these two side by side, as you can see here, type 1, you're going to have that upsloping of that ST segment and then a biphasic drop-off of that T wave. In type 2, The ST segment follows the isoelectric line, and you have a negatively deflected T wave that is symmetric in appearance. And that is going to follow all the way down on all of those precordial leads. Type 1 is specific to V2 and V3 specifically. Let's move on to our next section. Let's start off with a case study. We have a 62-year-old male, sudden onset of chest pain, substernal in nature, shortness of breath, respiratory rate currently at 22, pulse 110, BP hypertensive at 190/90. He has a SAT currently of 88%. He's on a cannula at 4 liters. And you're told he's got a past medical history of type 1 diabetes and hypertension. Now let's jump into our second part of our WALDO's SHIP acronym and look at A. And A is AVR. And we know that the evidence has shown, we did a podcast early on, 5 or 6 years ago on this subject. AVR used to be looked at specifically for one thing, and that is, hey, are our limb leads correct? We should have a primary negative deflection in AVR if we have a supraventricular in origin, rate, and rhythm. As long as your limb leads are correct, you should be negatively deflected. But as the evidence has shown, AVR is very diagnostic for one thing, and you should be paying attention to AVR. I want you to notice if we look at this entire 12 lead, we first look at V1. V1 is always the first lead you look at. You identify, hey, do I have a wide QRS, confirming that your QRS duration is less than 0.12. Once you've ruled in or out a bundle branch block, you move on, and you can go to axis. I always go to axis. I look at 1 and 3. I do the whole saying of let's left points away, right points together. This patient has left points away. Lead 1 is positively deflected. Lead 3 is negatively deflected. And so I know I have a left axis deviation. Without the measurements, without looking at the actual axis measurement, I don't know if this is physiologic or pathologic. And that's not really the point of this section. The point, though, is to get in a systematic approach every single 12 lead. So if we then look at this from the global perspective, we start looking at this 12 lead. If you start with 2, 3 AVF, you can definitely see, hey, I've got depression in those leads. Or you could even say, hey, I've got reciprocal changes in those 3 leads. And we move up and we look at 1 in AVL. Notice we have no ST elevation. We might have some depression in lead 1. And then we go up to V1 and go through V1, 2, 3 and move all the way down to V6. And we definitely see that we have anterior moving into lateral depression. Let's go back up to AVR and notice we have ST elevation in AVR. We also have a mild amount of elevation in V1. So what this means, guys, is if you have ST elevation in AVR that is greater than ST elevation in V1 with associated anterior depression, that is highly suggestive of left main insufficiency. And what they're finding with these patients is they're taking them to the cath lab and they're finding 3 vessel disease processes off the left main greater than 95% in most cases. And these patients are ending up in open heart surgery having a CABG. And so what we're doing with AVR is we're identifying these big, huge, high left main occlusions affecting, multiple vessels days to weeks prior to that big widowmaker. So the key is using AVR. If this is something that is not looked at in the area you work, this is definitely something to share. Go have a conversation with the cardiologist. Go talk to whoever is over the cath lab and find out, is this an MI equivalent that you can say, hey, I've got a STEMI activation and take this patient to the cath lab. I know from the aeromedical side, when we really looked at this in Kentucky, we had over a dozen patients with AVR elevation that we were able to take to a cath lab. And all of them had significant disease process. So I think this is a big, big deal. This is something you should be focusing on. Don't hesitate. If you see AVR elevation like this, pull the trigger, get them to a facility that can handle this patient. If we continue, now let's look at L for WALDO and look at left bundle branch block. We know that left bundle branch block has always been looked at as a mimicker. We know to diagnose a bundle branch block specifically, you have to have a QRS duration greater than 0.12. If it is equal to 0.12, that is not a bundle branch block. It has to be greater than 0.12, and we use V1 as our diagnostic lead. We cannot diagnose a bundle branch block in a 2-3 lead monitor quality tracing. It has to be a 12 lead V1. And so we always teach to look at V1 first because we want to immediately know, hey, I have a bundle branch block, and we know that that mimics ST elevation. We have to use different criteria once that is in place. We know we have two separate sides of our conduction system. Obviously, our right bundle that feeds into that right ventricle. But for the purposes of this, the left bundle has two fascicles. We have, number one, the posterior fascicle. The posterior fascicle is supplied by two parts of the heart, really two coronary arteries, the posterior descending off the RCA and the circumflex branch off the left main. So when you see somebody with a posterior fascicular block, just understand that that is a significant diseased heart. And then we have the anterior fascicle, and that is supplied simply by the left anterior descending. And that is a very common fascicle to be affected based on that insufficient flow in that LAD. How do we identify bundle branch blocks? Well, as I said, the first thing we do is we always look at the QRS duration. If it's greater than 0.12, we know we have a bundle branch block. Number two, we use the steering wheel method. This is something just for teaching purposes, probably review for most of you. And I always think about it from this perspective. If I'm driving a car from this direction and that car is stopping at a stop sign, we'll say V4 is that stop sign. If I'm going to turn left, I'm going to push my blinker down and I have a negative deflection. And so with a QRS greater than 0.12, negative deflection, that's a left bundle branch block. In comparison, if we go to a right bundle branch block, it's exactly the same. We're driving our car, we stop at the stop sign, we're going to turn right. We're going to push our blinker up, and now we have a positive deflection, and that's a right bundle branch block. Again, QRS duration has to be greater than 0.12. So how do we look at that left bundle branch block? We know that it's always been looked at as a mimicker of ST elevation. And if you look at this lead here, that's a great example. This looks like we have a significant amount of ST elevation. But this is a reflection of that wide QRS. It causes this phenomenon. Dr. SGARBOSSA actually did a study. She's a cardiologist out of Texas. And it was a pretty large study. And it really was looking at the association. Was there any association, any pattern recognition that they could attribute to patients with potentially new onset left bundle branch blocks? Was there anything that they could identify? Because we know that left bundle branch blocks in the association of an MI, 40 to 50% pump failure rate, very high mortality rate, 50 to 60%. And so that was always an area that when we look at in the past that we would stay away from. We didn't know if this left bundle branch block was new or old, and these were exclusion criterias. So let's look at the three criterias. We have 10 points possible. We have to have 3 points minimum to say, hey, this patient has a likely MI that's causing the left bundle branch block. We have a occlusion in that left main, somewhere in the left main, causing insufficient flow to the left bundle, causing this block. Criteria 1 is concordant ST elevation greater than or equal to 1 millimeter. If we identify that, we have 5 points. Now, the aspects of concordant ST elevation I want you to notice is this first lead here. That means you have to look at primary R wave leads, primary R wave leads only. Criteria 2 is ST depression greater than or equal to 1 millimeter in V1, V2, or V3. Doesn't have to be all three. That's 3 points. And lastly, you have discordant ST elevation equal to or greater than 5 millimeters. And that is looked at as excessive discordance. And that's 2 points. So let's practice. If we look at this 12 lead, first thing we do, we look at V1. We identify, hey, do we have any wide QRS? And you definitely can see this. I always advocate to go up to the measurement, look at it, and you can see the computer is always going to be accurate from the measurement side. And we're at 0.13. So we know we have a bundle branch block. We also know we're negatively deflected. And so we have a left bundle branch block. We have left points away, right points together. We definitely don't have left points away here. We have right point together. So we have 1 is negatively deflected, 3 is positively deflected. They are pointing towards each other. If you know the number measurements around the axis, you can definitely see here where I have it highlighted, we're at 108. And so that is a right axis deviation. But when we look at this from the MI standpoint, first criteria, because we can't look at this from the ST elevation standpoint anymore. Right? If you look at V2, V3, V4, V5, we could easily say, if we didn't understand that left bundle branch blocks cause that mimicking of ST elevation, that those definitely look like they are significant. But again, we have to look at this different. So criteria number 1 is, do we have any concordant changes? Primary R wave leads are the areas we're focusing on. And so that's usually going to be in 2, 3, AVF, V4, V5, V6. And we definitely see that V5 here has concordant changes, meaning we have a primary R wave, we have an ST segment. Both of those are above the isoelectric line. They're both moving in the same direction. They're mimicking each other. So V5, all we need is 1 lead. That's 5 points. Criteria number 2, do we have any ST depression of at least 1 millimeter or greater in V1, V2, or V3? And we can say we don't. Criteria number 3, do we have excessive discordance? So discordance, meaning we have a negative deflection, deep QS wave, big, huge ST segment going the opposite direction. So QS wave obviously is negative deflected, and then your ST segment is positive. It's above the isoelectric line. They're moving in opposite directions. Is there at least 5 millimeters of elevation? And you can definitely see that V3 here has 5 millimeters of ST elevation. So we have 5 points in V5. We have another 2 points in V3. And so we have 7 out of 10 points. As I said, all you need is 3 points. So this patient needs to go to a cath lab. They need to go have that investigation. So now let's dive into what's called D Winner's T wave. And really, these T waves are symmetrical. You're going to see these T waves as an upsloping, meaning that you're going to have this ST segment that's depressed, usually greater than 1 millimeter. You're not going to see ST segment specifically in those precordial leads. You may see some ST elevation, though, in AVR, and it might be just minute, 0.5 millimeter to 1 millimeter. So let's check this out. So when we look at this 12 lead, notice that you have depression pretty much globally. And you can also see that we have areas where we see hyperacute T waves. We also have areas where we see normal ST segment morphology. But specifically, when we look at our precordial leads, V2, V3 really stick out. You could see we have that depression, that ST depression of at least 1 millimeter. And then we have this steep upslope into a symmetrical peaked T wave. And so the key is to understand, do we remember about hyperacute T waves? And this is really hyperacute T waves on steroids. Think about hyperacute T waves as an ischemic process. And so this is just going to give you that high index of suspicion to say, hey, I've got a patient that really is presenting with maybe typical or atypical presentation. They may be pain-free. They may not be pain-free. Remember, women present completely different than men. But notice also AVR. AVR oftentimes will have, as we said, a small amount of ST elevation. And so this would lead you down the road of, hey, I've got that D Winner's T wave, that symmetric hyperacute T wave precordially. I've got AVR that is showing me elevation. That AVR elevation is greater than V1. So this is leading you down the road of a left main insufficiency of some sort, right? You might have multiple vessels off that left main that are impacted. Again, patient needs to go to a PCI center. Whether they take them straight to the cath lab or not, it's all about making a decision to get them to the right place. And that's the key. Now let's jump into O for out-of-hospital ROSC. I'm not going to spend a lot of time on this, guys. I think the key is once we get ROSC, we have to understand and think about what got us to this point. What was the events leading up to the arrest? What was the key to conversion? And remembering that you have to continue to make sure you resuscitate after. If you gave somebody sodium bicarb, and that was the reason why maybe they had ROSC, always suspect, hey, do I have a pH issue? Is my patient in a severe hyper-K state? Do I need to make sure that I am aware of minute ventilation? There's lots of different factors. Thinking about hemodynamic status, supporting that blood pressure afterwards, making sure that you have your airway managed correctly, and just globally resuscitating this patient. Now let's look at subtle inferior wall MIs. When we think about inferior wall MIs are a huge subgroup of our STEMI patients. And there's lots of research that have shown that those subtle inferior wall MIs are missed. And so there's been research all the way back, as you can see the paper on the left, 1993. And you can see a follow-up paper, and there's multiple papers you can look up. This was in 2014 that specifically look at what were the ways we could identify potential subtle inferiors where you may not see two contiguous leads. Even, you might have one small lead that's elevated. That doesn't really fit our standard protocol. We always know we have to have two contiguous leads. Some protocols say 1 millimeter of elevation. Others want you to have 2. And so I think the research on this has really shown that a subtle inferior wall is often missed and it's lethal. And so how are we going to pick up on that? I think these statistics are impactful. 61% of patients with that subtle inferior wall MI only had 1 millimeter of elevation. 87% only had one lead impacted. And 13% had no S elevation at all. But when you were able to look at and understand the reciprocal change seen in AVL, with just a 0.5 millimeter of depression in AVL, it was 97% accurate in identifying inferior wall MIs. Okay, I'm going to say that again. Go back up to the statistics. When you see 13% had no ST elevation, 87% only had one lead impacted. When you look up at AVL and you say, hey, we have depression, or we'll call it a reciprocal change, it was 97% in picking up that this patient likely has an inferior wall MI. So let's dive into that. I tell every single class we teach, every critical care course, when we do cardiology, I talk about this specific topic. When we think about reciprocal changes, there are two lead groups that are very, very specific to each other, and that's the high lateral wall, 1 in AVL, and the inferior wall, 2-3 AVF. And between those two lead groups, we have two leads that are twins. They are going to mimic each other very, very perfectly, and that is AVL and lead 3. So what I always tell every class to do is make sure to use that to your advantage. It is very diagnostic as a confirmation tool. And as we just highlighted in the research, it is very diagnostic in picking up those subtle inferiors. And we're going to learn it's also very impactful for those subtle lateral wall MIs. So let's look at here 2-3 AVF. I think you would agree that 2 and AVF, although you have some hyperacute T waves, they look very symmetric. You have hyperacute T waves really globally. only lead 3 has a minimal amount of ST elevation, and I would say that that is not up to even 1 millimeter. So this patient would not, unless they progressed, would not likely go to the right center. And if you started treatment, you started giving oxygen, you started doing what you do, and acquired this 12 lead, you may never pick this up. What we have to pick up on is to look up at AVL and say, wow, I have a reciprocal change there. Notice it's not as prominent in lead 1, and your ST segment is still following that isoelectric line. So once you see that AVL as a reciprocal change, look back down at lead 3 and notice that lead 3 has a minute amount. The key is recognition. This patient is likely suffering from that inferior wall MI. This is the same patient, guys. Same patient. Notice we still have that AVL, that depression. ST elevation in 2-3 AVF is still very minute. You can definitely pick up a little bit more in lead 3. Notice that the T waves in the precordial leads are starting to show a little pathologic finding. And this could lead us down the road to say, really, when we think at V3, V4, is there posterior involvement? And as we see here, more progression. T waves in the precordial side are becoming more hyperacute. You definitely see some depression forming in V3, really more V4. And then lastly, this patient progressed to ST elevation in 2-3 AVF. And there's no doubt. So there was early indicators with that first 12 lead, with that reciprocal change noted in AVL, that this patient was having an inferior wall MI. And that's the thing about this research. The research has shown that that reciprocal change seen in AVL or in opposite in lead 3 when we start looking at high lateral walls is very, very indicative of an early message to us to say, hey, something's wrong. Likely insufficient flow, occlusion is happening well before you see that ST elevation. So this is super, super impactful. So just to opposite, subtle, high lateral wall. One of the most common missed MIs out there, and I've read some research that says the number one missed MI out there is a high lateral wall. Just like we said, reciprocal change between AVL and lead 3, those are twins. If you see this big prominent reciprocal change in lead 3, look up at AVL. And notice that you have some ST elevation. You have a negatively deflected, or you could say a biphasic T wave, very small biphasic T wave in 1 and AVL as well. But would you actually call that ST elevation? Would that be enough for you to say, hey, this patient needs to go to a cath lab? If we look over at the precordial leads, you can see we have hyperacute T waves, V1, V2. And we also have that negative deflection, very similar to WELLEN'S type 2 in V5 and V6, actually V4, V5, V6. So this is another example. We can definitely see that we have a very slight amount of ST elevation in 1 and AVL. And again, use your reciprocal change to confirm that. Look down at the twin. Lead 3 definitely shows a reciprocal change. And then we can look across. We can look at our precordial leads. Do we have any other involvement? V1, 2, 3, 4, and then V5 and V6 are partners with 1 and AVL, right? That's the lower lateral wall. And those look benign. They look physiologic. So again, very, very subtle. Definitely see it more prominent in AVL. But would you call this a high lateral wall MI? Would you take this patient to a cath lab? So that is the purpose of this acronym. And again, I got to give all the credit to Jared Patterson for coming up with this acronym because I think it's so brilliant. It really will help you look at these atypical presentations and hone in on making sure the patient gets to the hospital they need to get to. Now let's look at H, right? H is going to be hyperacute T waves. This is nothing new. We've all learned hyperacute T waves. Hyperacute T waves are really, from a standpoint of evolution, the first indicator of an occlusion, and really short in duration, except when you look at that from the D-Winters T wave standpoint. Definitely an indication of ischemic processes, insufficient flow. And so when you look at the morphology of the T waves, there's going to be some differences when you compare it precordially versus limb leads. Precordial leads, you're going to definitely have a higher potential, usually going to be less than 10 millimeters. And you compare that to the limb leads, and you're going to basically cut that in half, and it should be less than 5. When we look at this and compare this to other presentations, it comes back to recognition. It comes back to talking to your patient, listening to your patient. Is it atypical? Is it not atypical? It comes back to, it could be just an ischemic process. You're early in the identification. Now, when we look at this 12 lead, there should be some things that really stick out to you. Number one, we definitely have hyperacute T waves. Again, remember, in the limb leads, usually not going to be greater than 5 millimeters. And you can see that in lead 1, 2. But when we get over to our precordial leads, notice V2 and V3. That looks just like that D-Winters T wave. Remember, we have depression of that ST segment of 1 millimeter. We have a steep upslope. And we definitely see the same pattern. And then remember, that D-Winters T wave likely has a 0.5 millimeter to 1 millimeter of elevation in AVR. And usually that's going to be a biphasic T wave. And we definitely see that. And so the key is getting this patient down the right road, getting them treated accordingly, moving towards a PCI center. May not be a classic STEMI activation, but what I always say is get them moving to the facility that can take care of them. Ultimately, it's about making good decisions, being an advocate for your patient, and moving them to the right facility. Lastly, guys, we're going to touch on those isolated posterior wall MIs. This is always a hot topic. And when we think about posterior wall MIs, I know some out there think it's great. Hey, let's always do a posterior wall 12 lead. I've never subscribed to that. You know, I've had this conversation with hundreds and hundreds of students in our courses. And there are some legitimate, strong responses. And I think when I hear the responses, I think they're valid, right? I don't think one size fits all. I think there's definitely opportunities. I think it's great from a training standpoint. It's great for constantly recognizing that, keeping that in the back of your mind. But again, when you look at the research, an isolated posterior wall MI is less than 3.3%. Some will say maybe up to 7%. But those are still small numbers. They're most often coupled with those inferior or lateral walls. And so how do we identify these from an isolated standpoint? The key is, for me, if I'm going to do a posterior 12 lead, it's going to be that patient that has no ST elevation. They look like crap. They look terrible. They have the presentation, right? They have the chest pain. They're diaphoretic. They look the part, but I'm not finding anything on my 12 lead. Maybe I identify reciprocal changes in V1 through 4, and we'll look at that. Maybe I don't. That's the time to do a posterior 12 lead. If I've already identified with my 12 lead acquisition that I have an inferior or lateral MI, they're already going to the cath lab. And I've talked to cardiologists, I've talked to nurses that work in cath labs on a daily basis that really say the same thing. They echo the same thing. It doesn't matter. Where it matters is identifying the isolated posterior, because they are highly fatal, because we miss them. If you are going to look at that posterior wall, doing a posterior 12 lead, we're going to go along the same plane as V6. and do V7, V8, and V9. V8 is always, I always remember, it's right at the bottom tip of the scapula. But all you need is a 0.5 millimeter of elevation. So it's very, very minute. This is a great example of a 12 lead where you see global depression. Look at V1, we have a normal QRS duration. We don't have any bundle branch block. We can even look at the axis, 1 and 3. They're both positively deflected, and we can see our QRS axis right here is showing us that we are normal. So if we look at this just from the ST elevation standpoint, really the only thing that I'm seeing that is really fitting a potential, and it's still part of the WALDO SHIP acronym, is look at AVR. AVR actually has potentially a little bit of elevation. You definitely have a biphasic T wave. But notice V2, V3, V4 definitely has depression, or what we would say is reciprocal changes. So that is a great example of, hey, let's do a tracing and look at V7, V8, and V9. We'd simply cross out V4, cross out V5, cross out V6, relabel those with our pin. Let's look at another example. When we evaluate this tracing, you can definitely see that we have no classic ST elevation. If you look in the precordial leads, notice from V1, V2, V3, V4, even V5, you have a reciprocal change. And as we saw in the previous tracing, look at AVR. AVR looks a little suspect to me. Maybe a slight bit of ST elevation. Might only be a 0.5 millimeter, but we definitely have a biphasic drop off of that ST segment. And so again, this is not that typical ST elevation. So you need to have high index of suspicion, match it with how your patient's presenting, ultimately get them to a PCI center. Do a posterior 12 lead on this patient. See if you can get at least a 0.5 millimeter of elevation in V7, V8, and V9. And treat your patient. Another example. This patient obviously has some PVCs going on as well, but you can see globally there's no ST elevation, but you just kind of see these V2 and V3 stick out there. They don't match. And this, again, should focus you in on, hey, do we have a posterior wall? Isolated reciprocal changes in the precordial leads, specifically V2, V3, V4, is where it most often shows up. Always think about that posterior involvement. Let's do a few bonus. Number one is left main dominance. Remember, 10% of the population has left main dominant circulation. And all that means is that the circumflex branch does not terminate along that lateral wall like most patients. It actually extends back around and connects to the posterior descending that feeds that inferior wall. So when you look at a patient that is left main dominant, it is very, very easy to pick out. Notice here, 2, 3 AVF are elevated, right? We're significantly elevated. We definitely have an inferior wall MI. But if we look over at the precordial side, you definitely have reciprocal changes in really V1 through 4. But notice you also have elevation in V5 and V6. So this is, when you think about normal circulation, the circumflex branch is a branch off the left main. The inferior wall is normally fed by the RCA. These should not be affecting each other. And it's very unlikely a patient is going to survive and have two occlusions at the same time affecting the circumflex branch and the RCA. So where this occlusion is actually in the circ. The circ is feeding the posterior descending, which is feeding the inferior wall and the posterior wall. And that's why you're seeing an inferior wall MI. You're seeing reciprocal changes in V2, 3, and 4. And you're seeing elevation in V5 and V6. And so this is that inferior lateral, and I would also couple that with that posterior involvement. The thing that I have noticed, I've had lots of these patients are not going to be preload dependent like a normal RCA occlusion is. I've found them to be very hard to treat from the pain management side. They don't respond very well to medications. Whether you're using morphine like we did back in the day or fentanyl like we do now, it seems like nothing touches the pain. Let's do a case study. We have a 67-year-old male, calls 911. He's got general weakness. He's got a heart rate of 150, blood pressure 96/60, sat 92%. He's got a history of hypertension. He does drink quite a bit, and he's a type 1 diabetic. So we put him on the monitor and notice he's got this wide, complex rate and rhythm. So the key here is to always ask yourself, is this patient sick or not sick? I would say this patient is sick. He's got a fast rate. His blood pressure is still perfusing. We don't know what his normal pressure is. We would need to find that out. He could be a little low based on a normal blood pressure, but if the hypertension is being treated correctly and his blood pressure runs normal, that could still be a perfusing map. Ultimately, I would say he is stable at this point. So I think it's important anytime you have a fast rate, whether it is wide or narrow, always, if your patient is stable, they don't need cardioverted right this second, you always do a 12 lead. So let's look at this. We do a 12 lead, and I want you to notice some key elements here. If we think about standard ACLS guidelines, this is a teaching that is being taught a lot by FOAMfrat, and it really is to bring the light, the focus on, hey, ACLS is great. It really gives us a foundation, but there are some things with ACLS, if we treat things as cookbook medicine, we can definitely get into trouble. And so when we think about what this looks like, we definitely have a very wide rhythm. We definitely have a slower rate than you would normally see in VTAC. It doesn't mean that we can't have VTACs this slow. But there are some key elements here. And if we treated this based on ACLS guidelines, we gave amiodarone, or as the research has shown, lidocaine is just as good. Some may think it's better. Or we go procainamide. What's going to happen? ACLS is going to kind of do us wrong. So there's some key elements here we have to pick up on. The first thing is, anytime you see VTAC at this rate, always stop. That's a red flag. A slower VTAC should raise your red flags. Also notice how wide our QRS is. Remember, a bundle branch block is anything greater than 0.12. And if you measured this out, we're actually greater than 0.20. We're longer than a normal P to R interval. So let's highlight this. We look at differential diagnosis, guys. It's about, number one, looking at, hey, does AVR give us any indication? We teach this in other courses where you can look at AVR and identify, hey, is this VTAC or is this SVT with aberrant conduction? ACLS guidelines can lead us astray. So how do we treat this patient? And this is where I want you to kind of stop, take pause. Slower rate, wide QRS. Look at the patient, past cardiac history. Could this be a hyperacute state? What would happen if we treated this with ACLS guidelines? If we give amiodarone or really any sodium channel blocker, you're going to cause this patient harm. This patient will go into a Brady arrest and move into asystole. And so the key is, hey, treat this as a hyperacute state. Calcium gluconate. If you carry calcium gluconate, give that 1 amp. If you carry calcium chloride, give that. But remember, there's a 3-to-1 ratio. 3 amps of calcium gluconate equal 1 amp of calcium chloride. I would just give that 1 amp of calcium gluconate if you had that, and give an amp of bicarb and see what happens. And you should see this QRS start narrowing. Again, if you give your sodium channel blocker, the patient is not going to do well. And so, as I said, FOAMfrat has really been focusing on this because he's seen even physicians make this mistake. We get tunnel vision based on the ACLS side. I would repeat the 12 lead and then identify, is the patient getting better? Is the QRS narrowing down? And so think hyperacute. Normal QRS duration, as I said, should never ever be greater than 200 milliseconds, or that equates to 0.20. What he identified and named this that I think is funny is a really, really wide complex tachycardia. And ACLS, as I said, is a great foundation. It gives us a lot of great insight, it gives great algorithms, but sometimes we can get tunnel vision and we have to think outside the box. And this is what this example is all about. Have caution, slower VTAC, wide QRS, slow down, assume it's hyper K. Lastly, we're going to touch on BRUGADA syndrome. BRUGADA syndrome is more of a rarity as well. Very similar in context to WELLEN'S syndrome from the appearance standpoint. It can very easily be, misconstrued, and I've seen multiple case reports where that's exactly what happened. The difference between BRUGADA syndrome and WELLEN'S, though, is this is more of a sodium channel anomaly. You're going to see normal QT intervals. These patients are going to have painless presentations. You're not going to have the classic chest pain, but they're going to have atypical presentations, or they're going to explain a history of atypical presentations, syncope, dizziness, maybe labored breathing or shortness of breath, maybe runs of palpitations. And most often these patients are 40 or less, and it's more common in Asian descent. And so these are going to be those young patients that have sudden cardiac arrest. So let's look at this 12 lead. If we compare this 12 lead and really dive in, I want you to focus on V1 and V2. If you remember back to our first couple slides on WELLEN'S syndrome, very, very close in appearance, but I want you to compare it when I put this picture up that WELLEN'S syndrome has more of a gradual upsloping of that ST segment, specifically WELLEN'S type 1, whereas BRUGADA syndrome just comes straight up. It has that coved appearance. ST elevation is going to be at least 2 millimeters, and you're going to notice a difference between V1 and V2, and that is very synonymous. Is one lead is going to be greater than the other. And so V2 definitely has a greater amount of ST elevation than V1. And then it's always followed by a negative deflected T wave. BRUGADA is going to show up in V1, 2, or 3 specifically. And so again, think back at if this patient wasn't in cardiac arrest, right? Did they have any past history, atypical presentations, right? They're young, less than 40. Again, Asian descent is the most common. Do they have recent syncope? Do they have shortness of breath? Do they have fatigue, right? Have they had this feeling of having fluttering in their chest recently? Couple that with a 12 lead and seeing this on the 12 lead. Big deal, because these patients are going to need an implanted defibrillator. In summary, the most optimal diagnosis when we look at 12 lead interpretation is really using the same approach every time. And I highlighted that very quickly. I always go to V1 first. I make sure I don't have a wide QRS. I confirm with my measurement. Then I move to axis, and then I start looking at my 12 lead. Using that systematic approach is going to really give you insight, right? You repetitively do this over and over and over. It's going to greatly increase your chances of identification. And that's ultimately going to increase the chance of reperfusion for these patients. Ultimately, 12 lead interpretation has become not just about the 2 contiguous leads, but has become about evidence-based practice. If you have any questions, please put it in the chat, and I will attempt to answer anything. If you want to email me, eric.bauer@flatbridgeed.com, I will answer that email, and I will get right back to you. As always, thank you for joining us, and I will talk to you soon.